This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
Thank you very much. So about a year ago, Daryl told me what I was supposed to be talking about. And I just went to a talk about delirium, and maybe I've been delirious for the last year because I can't remember. So I'm going to talk about, as usual, what I want to talk about. Now, a colleague of mine said, you know, have you seen the Rapid Response Team bus? And this is a Billy Graham bus to carry evangelists out to disasters. Okay, and they all hop in the bus, and if there's a typhoon, they call them in North America, if there's a typhoon or an earthquake or some other sort of fire, these evangelists get on the bus and go out and counsel the natives, go and counsel the people who have been affected. And so two things struck me as really important. They're calling us a rapid response team, and quite a lot of our focus, because we're evangelists about rapid response, quite a lot of our stuff is around the rapid response team and the imposition on the ICU that the team causes and the cost and the people being off the ICU and what have you. But in reality what we have is a rapid response system. And we need to remember that. It's more than the team. Okay? It is a system. And if you're going to be the ICU director that's running a system, you have to look at all the things that system encompasses. Now, I had to put this slide in. Piconi told me that if I didn't have something about the standards in my talk, I could look for another job. And after today, I might be looking for another job anyway. So you're all aware that the Commission did a lot of work trying to nut out the elements of this system and their clinical process issues and their organisational issues. And one of the things I think lots of us get completely bogged down on the clinical processes and lose sight of the fact that there are organisational things that need to go on around the rapid response system that are actually much more important and give you, as people in the ICU, the possibility to reform the whole of your hospital because it reaches into everywhere in the hospital. And there's lots of guiding principles all on the Commission website. Now, in my view, healthcare is a bit like this. It's like two rugby teams in a scrum. There's a whole heap of stuff going on there, but we don't see it all from the outside. That's the first thing. The second thing is that the team thinks they're all there is. Okay? If you're a member of that team, that's all you're about. But in reality, that team is supported by a whole heap of other people. There are team managers, there are coaches, there are physios, there are doctors, there's crowds, there's supporters. So the team is self-obsessed with the team, but in reality, that team's being supported by lots of other things. And I guess one of the things, the messages out of my talk is these rapid response systems are much more than just looking at the team and how the team's activated and what happens with the team. They're looking at the whole system within your hospital to support sick patients. So, what does the system include? It includes ward observations, their time, their frequency, their method, what's measured. In our hospital, when we did a survey, there were 29 different combinations of times that nurses recorded observations. So you're given the opportunity to go and standardise all that. There's stuff around charts and triggers, single point or scores. There's escalation plans. You know, our hospital was proud that the wards knew who to call. When we went and actually investigated that, they didn't. Lots of wards didn't know who to call. They knew who to call Monday to Friday, 9 to 5, but out of that, they had no idea. It's about how you get responses, who you call, whether the hospital paging works, what the switchboard works like. It's around protocols, it's around documentation, it's around data, audits, technology, and it's most importantly, it's a hospital-wide engagement. And if, as the people who are running the rapid response system, you don't engage with the other clinicians in your hospital, then you're lost. So there are numerous stakeholders, including, we'll hear in a minute from Stevie, one of the hospital executives at one of the hospitals in New South Wales. There's clinical governance committees, there's directors of nursing and medicine, there's specialist medical staff, there's nursing unit managers, there's ward doctors and nurses, and so on and so on. And in fact, engaging with all of those people and having them understand what the system is and what their part in the system is a really important part of making it work. When I was a junior doctor once, I provoked a strike amongst the porters because I dared to wheel a bed around the hospital. Okay? So you've got to engage with all these groups or you run into trouble. And so the rapid response system gives you a chance to re-engineer the hospital. Now, I put it to you, when I was a junior doctor, and I know most of you will be surprised to hear that this was last century, the ward I was on had a patient lounge. Now, what was a patient lounge for? The patient lounge was where the patients went to watch telly. Okay? What did the patients have? They were in hospital for glucose tolerance tests, they were in hospital for random cortisols, they were in hospital for early morning cortisols. They were basically normal people off the street in a hospital wandering around those wards. Now, if you go to the same ward, the nursing staff level is exactly the same as it was back then, last century, but the patients don't use the patient lounge because none of them can get there. Okay? The world's changed, but our systems haven't. I put it to you that if Florence Nightingale morphed into one of our wards, she'd understand what was going on and feel relatively at home. You know, there's transient senior doctors who wander through, wave at the patients and rely on the NUM to tell them who the patient is, what they've done and what's supposed to be happening. And the nurses work in exactly the same way as they did 2 centuries ago. So I think one of the things to me is that this rapid response teams and system allow us to re-engineer the whole hospital. Now, our patients and our staff tell us what they think of our hospitals. This is one of the prominent Sydney hospitals, just looking at Google, looking at the comments in Google about what people think about this hospital. So the staff are very rude. I've been treated poorly after I had a foot operation. My grandfather was severely mistreated by poor nursing staff overnight. He's left sleeping on a wet mattress and blood on his sheets. What an awful hospital. Lack of communication is number one. No one knows what goes on. Some nurses and doctors are nice, some are terrible, and so on. So we do have to re-engineer our hospitals. We have to work out how we can look after sick people better, and we're in the prime position to actually engineer changes in what we do. Now, as an ICU director, I've been stunned by the ever-increasing number of rapid response calls. This is all of New South Wales hospitals. A1 hospitals are the teaching hospitals, which is what my hospital is. If you look at that, our hospital's got 72,000 separations. So taking the New South Wales average of 60 calls per 1,000 discharges, you're looking at 13 rapid response calls each day. And that's the average, okay, across the state. Yes, there are lots of calls, but remember this system is more than just the team. We've seen in this conference lots of talk about different charts, and this is one of the Queensland charts, which was based on a chart that Muse chart from Canberra. Again, lots of people get obsessed with the charts, but it's a system and much more important than just the chart. The chart's interesting. Tweaking the chart can do some really good things, but if you don't have the system around the chart's just a piece of paper. Similarly, people develop protocols. This is an Nepean hospital in Sydney. Again, the system's much more than just the protocol. And another criticism is the calls just keep increasing every year. This is our hospital. We have a multi-tiered response system, but you know, this is 200 calls per 1,000 separations for the ward staff to deteriorating patients, and about 45 or so for the ICU for deteriorating patients. That's a lot of calls, but you can, you can see that eventually, though, the calls seem to plateau. And we hope we can get to a steady state. And we hope that we're not de-skilling the wards and actually upskilling them by giving them education. And it's not a 24-hour-a-day operation. Some places have rapid response systems that only work on business hours. This is our data showing that, in fact, patients deteriorate at all hours, and that's 32% of patients are deteriorating between midnight and 8 a.m. So you need a system that's truly ubiquitous. And similarly, there's a criticism of these systems that everyone either gets admitted to ICU or they're made DNR. Again, our hospital, 25% admission to ICU, 6% NFR rate. Everyone else stays on the ward and either gets better or calls the team again. And another criticism is that the systems are too slow to be any use. So these are the times of our rapid response. For the pre-arrest or arrests, you can see that almost all patients are seen in under 3 minutes. Don't know what happened to our font there, but anyway. And similarly with ICU assist calls or our MET system, the vast majority of people are seen within under 10 minutes. Okay? So we are getting there in a reasonable time. And everyone dies anyway is another criticism of these systems. In our figures, even people who have had a cardiac arrest down here have a 54% survival rate. Not too bad. So the last criticism is it makes absolutely no difference to outcome. Again, this is Group New South Wales data by year of cardiac arrests within the hospital, the cardiac arrest rate per 1,000 separations. And as you can see, it's neatly coming down. Oops, on the last one. Nice decrease in cardiac arrest rates across the system. So the rapid response systems do seem to be working. So what are the cons as an ICU director having responsibility for the ICU but also responsibility for the hospital as a whole? If you take my view, then in fact this is an opportunity to re-engineer it. Yes, there are problems with resources. There are lots of calls and you need lots more staff and you have to engage with the administration as well as non-ICU staff to make sure that resources are shifted subtly to allow you to run the system. You've got a whole heap of engagement with everyone, and certainly lots of my colleagues when we were putting in our rapid response system said that wasn't what I trained for. I trained to be a real proper ICU doctor, and going out and looking at patients on the ward who are deteriorating isn't what I trained for, and it's not what we should be training our registrars to do. And I put it to them, you know, when I was a junior doctor, I thought about training in vascular surgery. And in those days, vascular surgeons actually did a laparotomy and repaired a ruptured abdominal aortic aneurysm by opening the patient up. Now a vascular surgeon in our hospital, we've got trouble getting any of the fellows in vascular surgery to ever have done an open AAA. The world changes. If you've got skills that will allow you to move into new areas, that's fantastic. It's better than being out on the scrap heap without having a future. So there's ICU hostility you have to deal with. There's ward hostility because you're interfering with their patients. You're taking over the hospital, which you are. You're downskilling the wards, which you shouldn't be because you should be putting in a whole heap of education to upskill the wards so they decrease their calls to you. And there's lots of education and lots of need to educate both the ICU staff and the wards. And overall, it gives you yet more responsibility, but it actually gives you the chance to frame the hospital around something that's sensible. So I guess my message to you is there's a lot of work setting up a rapid response system in a big complicated hospital. The most important thing I think is communication to all the stakeholders, and the stakeholders are way more than just the ICU and way more than just the ICU and the administration. And it's really every clinician, doctor, nurse, physio in the whole hospital are your stakeholders. And I think thinking aloud and thinking ahead, we need to get past the way we run wards as sort of team-based fiefdoms and move the whole hospital towards a system where you have almost like an HDU everywhere, where there are geographically based nursing and medical teams with senior supervision of those teams, and the surgeons and the physicians come in and give you their expert view, but in fact the ward is run just like an HDU with senior staff oversighting everyone and not just waving at 5 a.m. in the morning when they're off to go to their orthopaedic list. Thank you.